and cases more were identified. And as the year went by and as time went by with treatments, the mortality, which is those black circles, the mortality went down, 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 and now down. Now 2024, we have all these treatments, and the mortality is extremely low, less than 5%. Some of the terminology that you'll be hearing throughout this conference. First, we have autoimmune myasthenia gravis. This is acquired. Could be ocular, which is myasthenia restricted to your eyes, meaning droopy eyelids, double vision. If you have problems swallowing, if you have weakness of your chewing muscles, that is generalized myasthenia, even though it's not affecting your arms and legs, it is considered generalized myasthenia. It could be seropositive or seronegative. There are other terminologies that you'll be hearing about. There's something called immune checkpoint inhibitor induced myasthenia, and this is patients who get myasthenia because of a side effect of this medication, which actually is a family of chemotherapy medications. And then there's the congenital myasthenic syndrome, which is more of a genetic myasthenia, which we will not be discussing today. I don't think you'll be hearing about this conference. Prevalence in the United States, about 15 to 20 patients per 100 population. That's approximately 50,000 cases in the United States. Probably underdiagnosed, I think. Maybe the prevalence should be higher than that, but women are mostly affected in the third decades and males in the seventh decade. And historically, there's more females than male, but as the population becomes older, now we're having more men than female. And the weakness presents in specific muscles. It is painless. So if you have no symptom and all of a sudden you get a massive headache with double vision, droopy eyelid, it's unlikely to be myasthenia. Go to the ER, maybe some blood clot or something like that. You have severe neck pain, tingling down the arm, and your hand is not working, unlikely to be myasthenia. It's a painless condition. There's no sensory disturbances, no tingling, no numbness. And it's variable. It is generally worse at the end of the day or after physical activity. It's increased with sustained exercise, and it worsens with heat or elevated body temperature. About 70% of patients the myasthenia start in their eyes as ocular. About 15 to 20% of patients myasthenia start in their neck muscles, meaning problems swallowing, perhaps breathing, chewing. And about 5 to 10 starts in their limbs. Within the first year, about 75% of patients will have issues in their swallowing and in their limbs. About 67% of patients reach they experience their worst myasthenia during that first year. And 20% of patients can go into a crisis during that first year. And if your myasthenia is only restricted to double vision and droopy eyelid, there's about a 20% chance that it will generalize within the first year, and about 10% chance this will generalize in the second year. And as time goes on, that risk is lower and lower. On the top left, you see a gentleman with droopy eyelids, asymmetrical, one side more than the other. In the morning, barely asymptomatic, and now in the evenings, he's more symptomatic. That's a classic droopy eyelid or ptosis, asymmetrical ptosis in myasthenia with that fluctuation. Also on the bottom part, you see this gentleman with left-sided ptosis, droopy eyelid. He probably has a mild droopy eyelid on the right side as well, but he is compensating by raising his eyebrow or contracting his forehead muscle, the frontalis muscle. And that's why it doesn't appear that he has any droopy eyelid on the right, but I will bet he probably has a little bit of it. And eye closure is almost always weak. Even when you're in remission, you may have a little bit of weakness of your eyelid closure. And when you have double vision, this is a fluctuating, fatigable double vision. Sometimes objects are side by side. Sometimes they're one on top of the other. Sometimes there's a skewed. Sometimes you don't have double vision. And that's that fatigability that describes the double vision in myasthenia gravis. If you develop sudden double vision, and that double vision does not change, it's always the same, it's less likely that it's from myasthenia gravis. Sometimes you have to be resourceful and find what you have around to help you out. This is a patient, I went to the room and this is what I saw. He had tapes in his eyelids. After evaluation, he ended up having myasthenia gravis. Myasthenia gravis can also affect your swallowing muscles. You can have slurred speech, nasal voice after prolonged sentences. You can experience nasal regurgitation. That means, let's say you're eating rice, a piece of rice can come out of your nose. Disgusting. Difficulty chewing, particularly meats. And the more you chew, the harder it gets. Also difficulty holding your air inside your cheeks and protruding your tongue inside your cheek. That gets weak. Now, with myasthenia, there can be problems swallowing and problems breathing. However, those issues isolated without any other weakness is a rare finding in myasthenia. By far, if you have problems swallowing or if you have problems breathing, we can identify some of the weakness in other places that help us determine that your problem swallowing or your difficulty breathing is in fact from myasthenia. This is the myasthenic snarl, patient with myasthenia involving facial weakness. Their upper lip can contract, go up, but the sides don't go out, and you have this myasthenic sneer. The thoughtful resting posture, patients who have weakness with their jaw closure, so their jaw is always outward, and you can find them when you go into the room with a hand in their chin like this. Also, if they have a head drop or weakness of their neck extensor muscles, they can use their hand just to support their neck up. This is a patient with droopy eyelid, double vision, and you ask him to close your mouth, and this is as much as it closes. There's weakness of your jaw closure muscles. This is a drop head syndrome, and that's due to weakness of the neck extensors. Myasthenia can also affect your deltoid muscles, so difficulty reaching up high, tricep muscle, wrists, hands, and also down in the feet, your ankle weakness. There are many things that can worsen myasthenia. It can affect myasthenia. One of them is exercise. I believe later there's going to be a dedicated talk on exercise in myasthenia. But avoid overexertion, use your judgment. If it hurts the next day, you're probably doing too much. But overall, it's good within reasonable guidelines. Body temperature also affects myasthenia. So that's why if you want to exercise, it's advisable. Maybe you want to get a cold shower before you exercise and right after exercising. Cold shower, that helps. Also, during summer times, you want to keep yourself cool. Because heat worsens myasthenia, then if you get a fever, that can worsen your myasthenia. Also, systemic illnesses, infections, flu, urinary tract infection, they can worsen myasthenia. Stress and emotional upset, that is debatable, and I am not going to get into argument today with anyone. But it's there. We know that thyroid fluctuations can worsen myasthenia either towards one side or the other side, either going up or down. And there is at least a list of medications that are known to worsen myasthenia. Also, it's important to know that if your myasthenia is brittle, if you're in the midst of an exacerbation, then you're more susceptible that these factors will worsen myasthenia. And if you're doing well, if you're on remission, either due to medications or just spontaneous remission, it is less likely that these will impact your myasthenia, but you should still be cautious. This is the list of medications that affect myasthenia. I would suggest you take a picture of it. It's also available in the MGFA website. Everybody with myasthenia should have this list on their pocket. And when you go to your doctor and he says, well, here's a new medication, here's a new antibiotic, we're going to start you on this, that's when you want to take out that list and cross-reference, make sure it's not in that list. The ones that are bold are more notoriously known to worsen myasthenia, but in general, they can all affect myasthenia. So how do we diagnose myasthenia gravis? Well, there's the clinical presentation, which we just went through. Second way is through the ice pack test, then there's tensilon test, then the antibody testing, and last is electrical testing. This is the ice pack test. On the top, you see a lady with droopy eyelid. You put ice on the droopy eyelid, let it sit there for about 2 minutes, then take it out. And if there's improvement in the droopy eyelid, that's a positive ice pack test. It has about a 90% sensitivity. Sensitivity is the ability of a test to be positive when you have the condition. It's about 90% sensitive. Then there's a tensilon test. Tensilon is an IV form of mestinon. It acts quickly. So you have your symptoms, measurable symptoms like a droopy eyelid or double vision. You get tensilon IV, and then within a minute or two, you examine the patient and symptoms improve. On the left, you see the droopy eyelid and the facial weakness. After that, after tensilon, you see improvement. Here's another patient, droopy eyelid. Before tensilon, they get tensilon, there's improvement. We no longer have tensilon. Since 2018, the FDA discontinued tensilon. So tensilon is no longer is available, is not being manufactured. So that's one less tool that we have in our kit to help diagnose this. But the reason is because there was a high rate of false positive. False positive is when a test is positive, yet you don't have the disease. And that's horrible, where you get told that you have a disease and you don't have it. And there's a high rate of false positive. On the left side, you see a patient here with a droopy eyelid on the right. You see it's about 1 millimeter opening. And then after tensilon, you see it gets better, about 3 millimeter. So that's a positive tensilon test. You get stamped with myasthenia. Now, is this really a positive tensilon test? And that's where experience comes into place. You see this patient, look at his forehead. He's using the frontalis sign. He is raising his eyebrows and contracting his forehead. And that lifts his eyebrow. That lifts his eyelid up. So this patient did not respond to tensilon. Okay? And we might think just based on the opening of the eyelid that a patient did. That's an example of a false positive. Okay? Actually, not a false positive. That's an example of a false positive. The test was positive, but he doesn't have myasthenia gravis. Now, serological testing, I will not talk a lot about this because there is a dedicated talk about serology, but in our neuromuscular junction, in our muscle memory, we have several structures there that our body can make antibodies against, like the acetylcholine receptors, like the MuSK, like the agrin or the LRP4. The most common one is the acetylcholine receptors. About 80% of patients with generalized myasthenia gravis have elevated acetylcholine receptor antibodies, and about 50% of patients with ocular myasthenia gravis. If you have striated muscle antibody is positive, let's make sure that we get a CT scan of the chest because that's associated with phimomas. reality is, if you have generalized myasthenia gravis, everybody should be getting a CT scan on the chest, even if that antibody is not present. MuSK, about 40% of patients who are seronegative will be MuSK positive, and LRP4 is about 15% of patients who are seronegative. Another way we can diagnose myasthenia is through the electrical testing, and there's two types of electrical testing. There's the repetitive nerve stimulation, and then there's the single fiber EMG. This is the repetitive nerve stimulation. Some of you are going through palpitations right now and sweating, but it's a not so jolly test. And what we see with this test is, if you know nothing about what you're seeing, basically we're stimulating a muscle multiple times and you see this waveform. The lower the waveform, the weaker you get. And when you see that with multiple stimulation, that graph starts getting smaller, 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 smaller. And that is evidence of a neuromuscular junction transmission disorder. The single fiber EMG is this little tiny needle that goes between two muscles. And we take very precise measurements of the time it takes to contract one fiber against the other fiber. And this is what it looks like. You see the first fiber and then the second one. And as we do this multiple times, you can see how the second one starts juggling around back and forth, and then it does not appear. It blocks, and that equals to clinical weakness. And these are the two tests that we have from an electrical standpoint. Now, how good they are. What is the sensitivity of all of these tests? Sensitivity, remember, is the ability of a test to be positive when you have the disease. And what I want you to look here is that none of them is 100%. If you have generalized myasthenia gravis, it's more likely that one of these tests be positive. Also, I can tell you that if you get tested when your muscles are weak, that also enhances improve the chances of that one of these muscles are positive. One of these tests gets positive, particularly the electrical testing. So moving on to treatment modalities. First, we have the lifestyle modification. We already talked about exercise and medications to avoid. Know your body. You got to recognize your symptoms. And then we have the pharmacological treatment, and that we divide that in symptomatic treatment with mestinon, and then the immunomodulator treatments. And within the immunomodulator treatments, we have prednisone, and then we have oral stuff like Celsep and Imuran. We have IV treatments like Soliris, Ultomiris, Vyvgart, and then we have subcutaneous treatment like Vyvgart, Hytrulo, and zilucoplan. We also have interventional procedures like plasmapheresis and IVIG. There's also interventional procedure, and this is more for refractory management, and this is currently under experiment, but there is some stem cell transplant that right now is being looked into. And finally, there's surgical management, which we already discussed. This is a timeline, 1930s, we got mestinon and first thymectomy in 1941. Then prednisone came around. Some of the older immunosuppressants like Imuran, which is azathioprine. 1980s, we get plasmapheresis and IVIG. And then 1998, we get Celsep. To year 2000, we have Rituxan available. Then 2017, Soliris. 2021, we get Vyvgart. 2022, we get Ultomiris. 2023, last year, we have 3. Vyvgart, Hytrulo, Restigo, and zilucoplan. What's up next? There's a whole list of clinical trials going on. There is going to be a dedicated talk on this. But at the end of the day, we're all striving and we're all wanting a cure. So, to understand these medicines, we need to know about the pathophysiology of neuromuscular junction. We need to know how myasthenia affects the neuromuscular junction in order to understand how and why these medicines work. And this is the neuromuscular junction. You'll probably see a picture like this many times during the following 3 days. But when we contract a muscle, when I do this, there's a signal, electrical signal comes from my frontal cortex in the brain, all the way down to my spinal cord, out to the brachial plexus, into my nerves. And then eventually this ends in the nerve terminal. Here on a peach color, you see the nerve terminal. And you can see right here, this is the nerve terminal, and this is the electricity coming down and down and down. Once it reaches this nerve terminal, there's some channels, calcium channels, they open, and that releases acetylcholine. Those acetylcholine vesicles get released, and now you have all these acetylcholine molecules in this space between the nerve and the muscle. That is a space called the neuromuscular junction. And then after they're all hanging out, they're all in that space, having fun. And then they find an empty acetylcholine receptor. The acetylcholine receptors are located in the muscle. This is the postsynaptic membrane, and you have the receptors right there. And once that acetylcholine attaches to the receptor, that receptor opens, whole chemical reaction occurs, and that leads to muscle contraction. So any defect in that process will cause weakness. So there's 3 ways that myasthenia affects, myasthenia causes weakness. Number 1, we talked about the antibodies, bad, confused antibodies, and they come and they block and they sit on that receptor. Okay, so whenever you have that antibody blocking that receptor, then the floating acetylcholine can't find a receptor. And if the acetylcholine does not attach to that receptor, then contraction does not occur. That means weakness. On your right bottom, you see in green, that is the MG antibody, and it is occupying that space for the acetylcholine. And whenever that happens, now the floating acetylcholines can't find that space. So contraction does not occur. Now, based on this, there's one more thing I want to tell you, and that's about the acetylcholine esterase. The acetylcholine esterase is that little Pac-Man in burgundy right there. And this little Pac-Man, the acetylcholine esterase, he is also floating around that neuromuscular junction, and he's eating away all the acetylcholine. Okay, and that's important to know because that's how mestinon works. If you want to know how mestinon works, you need to know about the acetylcholine esterase. So the way mestinon works is mestinon attaches to that little Pac-Man enzyme. So when that Pac-Man enzyme has mestinon in his mouth, now he can no longer eat all of those floating acetylcholine. And when all of those floating acetylcholine, when they accumulate and accumulate and accumulate, they can eventually gang up and they can push away that bad antibody from the receptor. That's called competitive inhibition. Again, mestinon shoved into the Pac-Man's face. Now there's nothing eating away the acetylcholine. Now all those acetylcholine, they're now accumulating. And once they accumulate, they will gang up and they will push and scare that antibody from the receptor. One last picture, very similar. You have the esterase, mestinon is the X. When you eliminate that enzyme right there, now you have all those blue acetylcholine that will accumulate and will push away that IgG antibody out of the space, out of the receptor. Mestinon 60 milligram tablets, they are scored. There is a long-acting time-span formulation. Also, there's a syrup formulation. And there's also an intramuscular formulation that's mostly for cases where you can't swallow. There is also an IV form, but please don't let anyone in a hospital give you the IV form. Okay, and that causes problem with heart unless you're being monitored in an ICU setting. You should not be receiving the IV form of mestinon. Mestinon works at the neuromuscular junction. It just works with that enzyme. It does not affect your B cells. It does not affect the production of antibodies. Okay. And it just provides temporary improvement. So that's why it's called symptomatic management. It doesn't alter your immune system. And it starts working about 15, 20 minutes. And then that improvement peaks in about an hour. And then within 4 hours or so, it starts to decline that benefit. And that's why many of you would need an additional mestinon. And that's when the first one kind of decline. The response is often incomplete, variable, and many patients need multiple doses. Some patients need more, some patients needs less. Typically, we start with 30 milligrams 3 times a day, and then we increase or optimize as tolerated. And the most common by far side effect is diarrhea, also can cause nausea, vomiting, abdominal cramps. Also, liquid coming out of your nose, eyes, okay, saliva, muscle twitches and cramps. Now, if you take too much mestinon and you take too much mestinon, you'll have all the above. Plus, your pupils are going to get small. You can have cardiac rhythm problem with slow heart rate, so you can become lightheaded, and the myasthenia can actually worsen. So too much mestinon is not good. We already talked about the antibody blocking the receptor, but there's another problem. And what happens is, when you have a receptor that is being blocked, well, that receptor is not being used. And you've heard the term, if you don't use it, you lose it. Well, that happens here. And if that receptor is not being used, then the muscle kinds of internalize or swallows it. And when that happens, now you have less number of receptors in your postsynaptic membrane. So not only some of the receptors are being occupied, but now you have less receptor, and that is a real problem. Here's a picture towards the left. You have the receptors that are being occupied by the myasthenia antibody. Those are not being used. They're not active. So you're just hanging in there, and eventually the muscle will swallow it down. And now with myasthenia, instead of having 6 receptors available, now you only have 2. In this case, you have 4. Instead of 6, you have 4. So there is a reduction in the density or the amount of receptors. Here's a pathology, electron microscope of your neuromuscular junction. And you can see the staining in dark on the left side, all that dark lining, that is staining of the receptors. That's a normal muscle, and the receptors are staining dark. Towards the right is a patient with myasthenia, and you can see that lining is very faint, almost non-existent. So that's a reduction in the amount of acetylcholine available because of that internalization. The third problem that we have, or the third way that myasthenia causes weakness, is through complement attack to the neuromuscular junction. We're going to talk about that complement attack in a minute here, but bottom line is that those antibodies are really bad news. They cause blockade. They reduce the number of available receptors, and they also activate the complement, which attacks the neuromuscular junction, the membrane. So we don't want them. And the question is, how do we get rid of them? To know how to get rid of them, we need to know where they come from. And they come from your blood. They come from your bone marrow. When you get a CBC, you can see there's a listing of red blood cells, white blood cells, platelets, and there's one of them called lymphocytes. And we have T lymphocytes and B lymphocytes. Well, those antibodies come from the B lymphocytes. Those B lymphocytes will differentiate into a cell called the plasma cell. So from B lymphocyte to plasma cell, and then the plasma cell will make antibodies. It makes IgG, which is more pertaining to this talk because the acetylcholine receptor antibody is an IgG. IgG protects us against bacteria and viruses, but in the case of the MG antibody, that IgG is causing damage. But plasma cell also makes all kinds of immunoglobulins, IgA, IgM, IgA, IgD, and all of them, they protect us in different ways. Here's an illustration where the B cell differentiates into a plasma cell, and then they make antibodies, and it'll go attacks to that pathogen right there. It could be a bacteria in purple or a virus, and that's how our body gets rid of it. Unfortunately, those immunoglobulins that plasma cell that makes the good antibody is also the same plasma cell that makes the bad antibodies, which are the ones that target our organs. So one way of reducing the bad MG antibodies is by getting rid of that getting rid of that B cell. If we don't have B cells, they don't make the bad antibodies. But they don't make the good antibodies either. So that makes us immunocompromised, which has been a big challenge in myasthenia management. Here's a list of medications that reduces amount of B cell population: prednisone, Cellcept, Imuran, etc. And this is an illustration. You have your B cells. Your B cell produces good and the confused IgGs. Confused IgGs attack us. So if we get rid of those B cells, now we don't have bad antibodies attacking us, but we don't have also synthesis of good antibodies to protect us either. Many of you have heard about prednisone. This is how it works. That little, what is it, pentagon in yellow is prednisone, and it attaches to the B cell membrane. Then it comes into it, invades the nucleus. In the nucleus, that's a captain. The nucleus is the one that has the instruction. And basically, it changes the instruction of the cell. So now no longer we're going to do X, Y, Z. We're going to commit suicide. And that's what prednisone does. It just kills the B cell. It changes the instruction inside the nucleus, and the B cell dies. And if we don't have B cells, then we don't make bad antibodies. We don't make good antibodies either. It's very effective. Prednisone works. Typically, it takes about 2 to 3 weeks to start working. Recommended dose is 1 gram per kilogram. That's about 60 or 70 grams, sometimes 80, depending on that's very high dose. So you start someone a very high dose, and about 6 weeks later-ish, you reassess 4 weeks later. And then once the patient is at its maximal improvement, then you start a slow tapering process of that prednisone. And that slow tapering is a process that takes about a year. It's not something that will be done within a month. If you are on prednisone, you got to expect side effects. It elevates your sugar. So if you have diabetes, it will worsen that. Your diabetes medication needs to be optimized. It also affects sodium and potassium. So there's a dietary talk later during this meeting. I'm sure they're going to talk about low sodium diets, high potassium containing fruits and foods, because of prednisone, you lose potassium. By the way, low potassium can also worsen myasthenia. Prednisone can elevate your blood pressure. It can also cause mood problems and jitteriness. He's now screaming at me. He is intolerant. That's prednisone. Okay. Easy bruising, acne, poor wound healing, increased infections. It can cause osteoporosis. Okay, so it's important for you to be on calcium and vitamin D if you're on chronic prednisone. Be careful about avascular necrosis, and that's probably one of the most feared side effects in RN as providers. If you're on prednisone and you get kind of sudden, severe pain in your hip, that could be avascular necrosis. Avascular necrosis is like a stroke of the bone and most often affects the ball and socket of your joint of your hip. And the most not unwanted side effect, especially with ladies, is the weight gain. So, what are some of the immunosuppressants? Reminder, these are the medications that lower B cells. If we lower B cells, then we don't make the bad antibodies. We don't make the good antibodies either. And there's a list right there. I will briefly touch on CellCept and Imuran being the two most common. These medications take a long time. Imuran to start working takes average about 6 months. So if you are really struggling and having problem with your swallow, having started Imuran is really not going to help you anytime soon. Okay, so you have to be mindful about the onset of the timing of these medications. Annual cost of Imuran actually not much. It's actually one of the cheaper medications. CellCept, Imuran obviously has a side effect profile that all we need to be aware of. And CellCept it works faster. Takes about 3 months just to start working. And it's more expensive than Imuran. And it also have a side effect profile that we all need to be aware about. So we spoke first about the medicines that lower B cells. Another way we can get rid of these bad guys is by removing them from circulation. Meaning the B cells are there, they're making IgGs, we're not messing with that, but once they're in our circulation, there's some treatments that we can use that will remove them, hopefully before they reach the target. And that will be plasmapheresis, Vyvgart Hytrulo, and Restigo. Plasmapheresis is not a medication, it is a process. It is an invasive process. You get hooked into a machine, the blood comes out into this apheresis machine right there, and it goes into a centrifuge. It just turns a spin, and then it divides your blood into plasma and cells. The plasma gets thrown away, and the cells get pushed back into your body. And that process is called plasmapheresis. Why do we want to get rid of the plasma from our blood? And the reason is because in that plasma, that's where all the immunoglobulins live. The good IgGs and the bad IgGs, also IgA, IgD, all the immunoglobulins live there. Okay, so by getting rid of the IgGs, now we have less IgGs, and we were able to hopefully improve myasthenia that way. It is very effective. Okay, it is every other day treatments. And the improvement is variable. Typically, it takes about 2 or 3 exchanges for you to start noticing improvement. And it's short-term improvement. Why short-term? Because our B cells are still there. Our B cells are still making IgGs. Okay? We're not messing with that. We're treating this more downstream. So that's why once the effect of plasmapheresis wears off, then these B cells are producing new IgGs. So that's how after 3 weeks or so, you can start worsening if there's not a plan B. And it's typically indicated for MG exacerbation, the MG crisis. If you're infected, if you have low blood pressure, you should not get plasmapheresis. There are complications from plasmapheresis, and it is expensive. You get admitted to a hospital with an MG crisis and you need plasmapheresis, the bill can be up to a $100,000. We already talked about plasmapheresis as a procedure, but there's a number of pharmacological treatments that will also remove IgGs from circulation. That will be Restigo, and that will be Vyvgart Hytrulo and Vyvgart. But to understand how these medicines work, we need to understand the concept of how our body get rid of IgGs. That's called IG recycling. And it is a basic concept, but it's a little complicated. So I'm going to try to simplify it here. On the top here, you see this red tube. That's our circulation. And that's where immunoglobulins live. They hang around, the good and the bad. In this picture, the bad are depicted in blue, and the good IgGs are in black and white. And after about 3 weeks or so, our body gets rid of them. That's to maintain a homeostasis in our body. Our body makes them, it eliminates them, and that maintains a control. If we make antibodies and we don't get rid of them, then our blood's going to be very thick and we're going to be stroking out, having blood clots everywhere. So our body gets rid of them. And this is how it does. This is how it does this. Once it's time for the immunoglobulin to really just go away, they go into this cell. And the cell is that big square right there. And within the cell, they go into this little bubble. And once they are in that little bubble, they try to find an empty FcRn receptor. FcRn receptors they look like this blue hockey pucks. And just bear with me here a second. Once they're in this bubble, they go find empty FcRn receptors. And if they find one, they get stuck to one. Now, the ones that are not bounded, the ones that didn't find an empty FcRn receptor, those get eaten out by the lysosome. But those actually that found an empty FcRn receptor, they go back into circulation. So you can see from 8 IgGs, we came down to 4 IgGs. So that's the way how our body reduces the amount of IgGs. However, if you have myasthenia gravis, you do not want your body to be throwing back into circulation the bad antibodies. We want to get rid of them. We don't want them to come back out, not in. And this is where these medications come into place. This yellow C-shaped is the medication, and they're hanging in the circulation with all the antibodies. And then when the IgG's time to die, they go into this cell. The cell goes into this bubble, and within that bubble, these medications have a higher affinity to the FcRn, meaning they stick first and faster to the FcRn hockey puck before the IgGs get stuck to them. That way, now we have more IgGs that are not stuck to the FcRn receptor. Remember that unbound IgGs, they get killed by the lysosome. And then the one that actually were bound, they get thrown into circulation. You repeat that multiple times, and you get a reduction in IgGs. Okay? Be mindful that this only affects IgG and not the other IgGs. Also, these medications, they're working at this level. They do not affect the B cells or the ability of B cells to produce IgGs, the good or the bad. And that's how Vyvgart and Rystiggo work. They bind to the FcRn receptor so that the antibodies, the good and the bad, they do not get recycled. And now they go to die at the lysosome. Okay? It doesn't completely eliminate IgGs. It reduces majority of them, but not all of them. So it's not an immunosuppressant. Word on Vyvgart, it was approved in 2021 for adults. Seropositive generalized myasthenia gravis is an IV medication, and a cycle constitutes a weekly IV infusion for 4 weeks, and then subsequent cycles are provided as needed. The time from one cycle to another cycle, it's variable based on the patient's condition. and does not require prior vaccinations. Others do. There is a side effect profile, and it costs about $230,000 a year. Vyvgart Hytrulo was approved last year, and it has the same indication, meaning adults, seropositive, generalized myasthenia gravis. It is subcutaneous medication. It has the same side effect profile. Efficacy is also about the same, and the cost is about the same. It goes under the skin. However, the FDA only approved it under supervision of a healthcare provider. So as of now, you cannot administer Vyvgart Hytrulo on your own. Rystiggo was approved last year, also for adults with generalized myasthenia gravis. Need to be acetylcholine receptor positive. Also for MuSK antibody, as a matter of fact, this is the only FDA approved for MuSK myasthenia gravis. It is subcutaneous. It is once a week for 6 weeks. That's a cycle. Second cycle is performed on an as-needed basis. And when is that done? That timing is variable between patient to patient. Some of them need it 6 weeks later. Some of them need it 2 months later, etc. And if we go side to side between Rystiggo and Vyvgart Hytrulo, the volume in the syringe is about the same. Rystiggo, it's an infusion over 50 minutes, but then you have to observe the patient for 15 minutes. Vyvgart Hytrulo is an infusion for only 1 minute, but then you have to observe the patient for 30 minutes, and that's FDA mandated. So at the end of the day, they're both 30-minute infusions. They're both subcutaneous. They're both have to be done under supervision, healthcare supervision. They have similar side effects and similar costs. IVIG. IVIG doesn't necessarily remove them from circulation, but this is what IVIG do. IVIG circles them and avoids them from reaching the target, okay? And that's how IVIG works. You infuse IVIG, and then they find the bad antibody, and then they will encircle them so that they don't reach the bad, they don't reach the target, in this case, the acetylcholine receptors. It is also a short-term treatment and wears off after a couple of weeks. Why? Because your B cell is still there and your B cell is still producing good and bad antibodies. It is indicated for myasthenia gravis exacerbation and crisis, also surgical preparation. Rarely is done for chronic maintenance, but it can occur also. And it's also expensive. You get hospitalized with an MG crisis. You undergo IVIG. Your bill could be about $50,000. Now, for those patients that needs or who uses IVIG as a maintenance for outpatient treatment, it's somewhere about $20,000 a year. Obviously, the cost can vary depending on brand, on where is it infused, transportation costs, pre-medication costs, etc. There are some precautions, particularly with kidney disease. If you have chronic kidney disease, you should not be getting IVIG. Also, if you have heart issues, particularly cardiomyopathy, you have long-standing hypertension and your heart now has enlarged, you should not be in IVIG. IVIG is a high volume, thick volume, and it makes your heart work more. That's why you shouldn't use it if your heart is already weak. It also makes your kidney work more. You shouldn't use it if you have kidney disease. Infusion-related reactions, most of these infusion-related reactions are mitigated by reducing the rate of the infusion. It'll make it slower. Yes, you're going to be in that chair for longer, but it improves that side effect profile. And there are some severe adverse reactions also that we need to be on the lookout, like low blood pressure. The most feared one, without a doubt, is the risk of stroke or pulmonary emboli, so some form of thrombotic event. Now, the third way, remember we talked about the first way was that that blocking. The second way is there's internalization, so now we have less amount. The third way that myasthenia causes weakness is by complement attack. And when that MG antibody, when the antibody attached to that receptor, that activates the complement. And that's a very complicated thing that not even I understand it well. You have a picture there, you're welcome to try to understand it. So this is how I have simplified this so that we can all understand how this works. I want you to meet Mr. C5. And Mr. C5 has been activated by that binding of the myasthenia antibody to the receptor. Now he's active. And he has a job to do, and that's to create this ultimate drilling machine. But he cannot do it alone. He needs to hire some people, some helpers, experts. So he comes in and hires Mr. C5b, Mrs. C6, and he hires Mrs. C7. And they all work together and then finally make the MAC. Meet MAC. This is the ultimate drilling machine. MAC stands for membrane attack complex. So when the antibody attaches to the receptor, activates this cascade of proteins, one binding with other and constructing this machine called the MAC. And towards the left, you can see a normal neuromuscular junction with all those green receptors that are living in the deep folds of the muscle. But then you have the drill, the MAC drill right there in the corner. And that complement MAC drill starts drilling and pouring holes into that membrane. And what happens, if you look toward the other picture there, you can see that the muscle no longer has these deep folds. And the number of the green receptors have now dropped down and there's less of them. Same pathology picture. You can see how those deep folds on your left, they're now on your right with myasthenia, they're non-existent. They're very shallow little folds there. And that's called simplification. What happened? The MAC drill just pour holes over the muscle membrane and now just destroy that landscape. So what's living there, those receptors are not functioning well, and that's bad news. Concentrate towards the right side. You can see Mr. C5 there. That's Mr. C5. And what you can see also there, Mr. C5b, C6, C7, and you can see how they all meet together and eventually they all meet together here and eventually makes the big MAC drilling. And then this pores that make holes into that membrane and screw it up. We need to know this because we have three medications here, Soliris, Ultomiris, and zilucoplan. And this is where they work. These three medications attach to Mr. C5 so that Mr. C5 now don't have the power to hire his friends and construct the MAC drill. So that's how they work. That's how Soliris, Ultomiris, and zilucoplan work. Notice that it works at the complement level. It does not reduce B cell population. Your B cells are still intact. They're still producing your good and bad IgGs. They're still doing all your immunoglobulins. So it doesn't lower your immune system. And it can even be used in combination with other medications for myasthenia. Briefly on each med, yeah, Soliris and Ultomiris, they're both IV. Same mechanism of action. Efficacy is the same. But the difference is in dosing. Soliris is every 2 weeks. Ultomiris is long-acting, so it's done every 8 weeks. It's been FDA approved for adults who have generalized myasthenia gravis and the presence of acetylcholine receptor antibodies. For both of these, also for zilucoplan, you need to have completed the meningitis vaccination prior to initiation of these medications. Zilucoplan, it also works in the complement, and it's indicated for adults with acetylcholine receptor antibodies who have generalized myasthenia. It is once a day. It is subcutaneously, and it's self-administered. Okay? This is other than the older pills, this is the first self-administered treatment, which is a game changer. Many of the other treatments are not self-administered, so they are infusion dependent. Being self-administered reduces the cost. Okay? It reduces the amount of appointments, transportation problems, and also give you some dependence back. But they're all expensive. They're hundreds of thousands of dollars a year. Soliris, Ultomiris can go up to $500,000. Vyvgart, Restigo, $250,000 a year. Zilucoplan, $200,000 a year. And I get many questions. So which one works best? Which one's more effective? Well, in black here, we have zilucoplan. In green, we have Vyvgart. In purple, we have Restigo. And in red, we have Ultomiris. And this is the primary outcomes from their each respective clinical trials. And on the top line of each of these squares is the placebo. The bottom line is the medicine. Towards the right means time, and the lower goes means improvement in myasthenia. And if everybody squints their eyes like this and look all four graphs, you can see that they all four looks the same. Pretty much. They all work. They're all effective. None of them works fully, complete. None of them work 100%. So be on something, they all work. Okay, there's, what might work for you might not work for the other patient. So when do you start any of these medications? When to start the immunosuppressants? When should my doctor start me on this? Well, first you go on Mestinon. Mestinon does not have any long-term side effects, short-term side effects while it's in your system. And hopefully many patients do well just on Mestinon. There's no need to do any of this treatment. Now, if you're not doing well, you're still symptomatic despite Mestinon, or you start having side effects to Mestinon, then by convention, we do prednisone. Prednisone works. Prednisone is extremely, extremely cheap. The price pales in comparison with the price of these other medications, so it's a preferred treatment. And on top of it, it works very well. So you start someone prednisone, and over time, you start taking them off prednisone. And hopefully, and many patients are able to achieve symptom freedom off the prednisone, and then you just keep them on Mestinon. And some patients just go on clinical stable remission without any medication. That's the best outcome. However, if despite prednisone, or if we're unable to taper you off prednisone, because prednisone is not forever, we just review the side effect profile. If we're unable to taper you off, that's when we go into the steroid tapering agents. And that's the whole list that we just reviewed. Now, which one to choose, that is a discussion with your doctor. There's different alternatives. There's different ways of administration. There's different costs. One of them is you can do it yourself. The other one, a couple of them are IV. Some of them are sub-Q. Ladies don't like sub-Q treatment because it can cause redness. So it's a discussion. They all work. So efficacy, they all work. Which one to use depends on many factors. Ultimately, And unfortunately, insurance has a lot of saying with regards what we can start new. Bottom line is that treatment is individualized. It's not a cookbook recipe where you just try one and then if that doesn't work, the other one. Everybody is different. Sometimes this one didn't work, then we try the other one. The other one didn't work as well as the first one. You go back on the first one, and it's a trial and error process. Ultimate goal is to have you have minimal manifestations of myasthenia or no manifestations of myasthenia, while on a medicine that is well tolerated, that you don't have side effects or very minimal side effects, and above all, that is not a financial burden to you. Again, nothing is 100% effective, so there's no promises. And some of the newer medicines are very convenient, but the convenient one might not work for you. So it's a trial and error. Maybe the ones that's IV that you don't want to do, maybe that's the one that works the best for you. So at the end of the day, insurance have a lot to say. In the future, I would really love to see a medicine, a pill that combines removal of the IGs with inhibition of the complement. That would be great. But such a thing does not exist. And right now we have many options, which is actually a good problem to have. Up next, I'm not going to discuss this much because there is an upcoming talk about clinical trials, but there's stuff out there. Okay, there's stuff out there. There's Uplizna, which we use for other neurological conditions. This one is one of those medicines that reduces B cells. There's also this other medication that starts with the letter B, and that one is a complement inhibitor, also inhibiting the formation of the MAC. There's another one. It's an IV. It's being tested in pediatrics. Okay, and this is one of those that removes the IGs from circulation. There are some upcoming clinical trials also on seronegatives. And there's the pipeline, there's stuff coming. So stay tuned, and we will be having a discussion about this with Dr. Vu later. And the future looks promising. We want safer option and also a broadening of the indications. We want to have ocular included. We want to have seronegative included. Also the pediatric population. So as you see, the MG 101 is really not so simple, but hopefully we were able to cover everything. And thank you so much. And I'll be happy to take questions.
Hi, first of all, thank you for coming back this year. I really liked hearing you speak last year. I guess my question is, since it is 101 and you were talking a lot about diagnosis, what I see a lot of in the support groups is when you're talking about being AChR seropositive, and in terms of diagnosis, which AChRs, all of them, only some of them. I see a lot of people suffering that definitely have the clinical presentation, but they're only positive on modulating or they're only positive on blocking, and therefore they're denied treatment. So can you just speak on that and to clarify which AChRs would make you?
Sure. If you have signs and symptoms of myasthenia, and any of those three, the acetylcholine binding, the modulating, any of those three, if they're positive, you are seropositive for the acetylcholine receptor. If you have MuSK myasthenia, then you have MuSK myasthenia. You're seronegative MuSK positive myasthenia. Same for LRP4.
We had a question online from one of our live stream, which was, can you explain what refractory myasthenia gravis is?
Refractory myasthenia gravis is a patient who have tried multiple treatments and they're still exhibiting weakness. So it's not the patient who's not on medication, is the one who have tried 1, 2, 3, 4, and it's not, nothing's working, and that will be a refractory myasthenia. I just want to clarify one thing. I mentioned that for the complement medications, that you need to have the myasthenia, the meningitis vaccine. It's not because those medicines causes meningitis. It's because those medicines reduce complement. And the complement system is what our body uses to get rid of the meningitis bacteria. So if you get meningitis while on these medications, then your complement is reduced. So your body really is not going to fight against that bacteria, and you'll need to rely on antibiotics. So the medicine don't cause meningitis, but reduces complement, and complement is needed to help clear bacterial capsules. That includes pneumococcus, Haemophilus, and meningitis, Neisseria meningitis.
Hi, my question is, can you explain, I was diagnosed about in 2018, but I had all the symptoms, drooping eyelids, slurred speech, losing the strength in my arms and my leg. And then, I guess I had the musk, was positive. So I'm still gets confused. I feel like I'm still newly diagnosed because I've been on Mestinon. I get the Rituxan chemo every 2 months. I get the, IVIG every 3 weeks, 4 hours a day, 4 days. So I guess the difference between what I have, then I guess another one, you can explain that. So is it the musk?
Be happy to. Musk myasthenia is a little bit different, behaves a little bit different than non-musk. Okay, tends to be more aggressive, affects more of the swallowing muscles, and Mestinon typically does not work on musk. In fact, it worsens myasthenia. So Mestinon is not for everybody. If you have musk, more likely than not, Mestinon will actually make it worse. So it's not the same. Yes, we use Rituxan. That's a treatment alternative. Also, Rystiggo was recently FDA approved for it. But it does not behave the same, and the treatment is not the same.
We had another online question quickly, which is a good segue. They asked, do you know what's in the pipeline for treatments for MuSK MG?
Yes, I just presented three medications here. And there is, I believe tomorrow, there's going to be a whole discussion on the clinical trials that we have for treatment options for myasthenia. Yes.
If you have generalized MG, can it turn into musk?
Well, musk causes generalized MG. Those are two different things. Generalized MG means that the weakness is occurring in muscles outside of the eyes, could include the eyes. So if you have generalized MG, means that you have weakness, could be in the limbs, could be swallowing, could be in the neck, could be in the throat, could be in your jaw muscles. So that is generalized MG. Now, being musk or LRP4 or acetylcholine, that is serology. That's more of the antibody testing. Now, most musk MGs are generalized. But I don't know if that answered your question.
Yeah, I have a question. Where do you guys know How does MG just all of a sudden show up in your body? Where does it come from?
I'm sorry, repeat the question.
Where does MG come from? Why does it show up in your body all of a sudden?
Today, we know that. Hopefully, we will cure MG. Why does our immune system gets confused and decide to start attacking our body? The day that that's fully understood, we will be able to cure hopefully all autoimmune diseases. Next year. All right, thank you very much.